Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Serare Ziai and myself, Dr. Guillermo Rocha.
The EyeCan podcast has been made possible by support from MD Financial Management and Scotiabank, proud financial partners of the Canadian Ophthalmological Society and Canada's ophthalmologists.
We'll share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Are you ready, Serare?
Let's do it, Guillermo.
Let's do it, Serare. On this episode of EyeCan, we talk with Dr. Ning Strube about her recently featured research on increasing safety in strabismus surgery and what simple changes can be made to have a significant impact. Dr. Ning Strube is Director of Pediatric Ophthalmology and Adult Strabismus at the Department of Ophthalmology, Queen's University, at Hotel Dieu Hospital, Kingston Health Sciences Centre in Kingston, Ontario. She's also an associate professor with tenure in the Department of Ophthalmology and has been cross-appointed in the Department of Pediatrics. Dr. Strube completed her medical school and ophthalmology residency training at Queen's University, followed by a fellowship in pediatric ophthalmology and adult strabismus with Dr. Kenneth Wright at the University of Southern California Children's Hospital in Los Angeles. She's both a fellow of the Royal College of Physicians and Surgeons of Canada and also a diplomat of the American Board of Ophthalmology. And it is great to be able to feature pediatric ophthalmology. As we have seen, often this field tends to be somewhat relegated, but I think after you hear this podcast, you'll see that it can also have some exciting research areas.
Ning, welcome to the EyeCan podcast. We're so happy to have you here, and we're excited to feature pediatric ophthalmology for the first time.
Oh, the first time. I'm so honored.
Exactly. Welcome. It's a special day.
It is.
Well, we've invited you because of this article that was published in the CJO. Can you tell us a little bit quickly, for those who did not see the article, tell us a quick summary of what the research covered and what are the hot points that we need to know?
So this is a collaborative study I performed with a few other authors, the main senior author being my mentor, Dr. Kenneth Wright in Los Angeles. And it really came about saying, how can we make strabismus surgery safer for our patients? The most dangerous part of our surgery is the scleral pass. Perhaps the two of you remember way back when in residency training. And as a teacher, this is the part that, gets our heart rate going and the gray hairs forming. And it's really a silly part of the procedure because one wrong move and you could potentially blind a child for life or an adult for the rest of their life. So Dr. Wright had a few patients where he said, I've tried this procedure where I use the hang back. So the traditional fixed recession, you place the sutures in the sclera and they stay where you intend the muscle to be replaced. With the hang back, if you recall, the sutures are placed in the muscle and the muscle is hung back from the insertion. So it's not actually sticking to the sclera immediately, and the sutures are placed anterior to the insertion. So hangbacks are safer for that reason, but there's some variability. And we said, is there a way to combine the safety of a hangback and the accuracy of a fixed suture? So we basically compared Dr. Wright's experience using this modified hangback technique with fibrin glue to the traditional fixed sclera. And really, we weren't trying to show superiority. We're trying to show, are the results similar? And in a nutshell, they were, with no complications. And since the publication of the study, we've continued to perform the procedure and teach it with great success.
That's great, Ning. Actually, you sort of alluded to the fact that maybe Serare and I, because both of us are cornea specialists, that we may not be as familiar with the strabismus techniques, but we are very familiar with use of Tecile. We use it all sorts of ways in all sorts of variations on the ocular surface. And so that's one of the things that actually intrigued me in terms of incorporating the use of Tecile to kind of secure the muscle in the hangback technique. Can you explain a little bit more about that? And I know one of the things with the hangback is that the muscle may move, but how effective did you find this? And did you compare this against traditional hangback techniques? And the other question I had was, what do you do with the conjunctiva after you've done that? Do you put it forward? Do you glue it as well? Or do you suture it or close it in the usual manner?
Okay, those are amazing questions. And I think there was 5 of them. So I'll start. Originally, way back when, one of our residents, who now is our program director at Queen's, Mark Bona, and my pediatric ophthalmology teacher at Queen's, Dr. Arthur, had looked at cyanoacrylate glue on a mesh to see, is in an animal study, but seeing, can we somehow, again, everyone wants to try and avoid this dangerous part of the procedure. And they found that was quite, created a very strong bond. So originally, Dr. Wright and I looked at cyanoacrylate glue as an adhesive. And, it's really interesting as an aside, negative studies are really not published that much. So we looked at this and found it was successful, but had glue extrusion and patients really weren't that comfortable with it. So we, again, thank you, CJO, published this negative study saying, although the results were good, we don't recommend cyanoacrylate. So then we looked at Tecile, which, as you said, we're probably one of the last specialties standing in ophthalmology that haven't used Tecile. And there's a few papers out there looking at Tecile alone or glue alone. And that's just not strong enough. The rotational force of an eye moving, the muscle will rip off. The technique is similar. We've used Tecile with amniotic membrane to prevent restrictive strabismus. So in some ways we're familiar with Tecile, and it, as you know, it's relatively straightforward to use. Placing the 2 components just under the muscle bed and over the sutures for the hangback, and just waiting. And as you know, you look at the clock, and that's the longest minute, 2 minutes. But what you mentioned is great. Now what we do is just have the conjunctiva lifted up. We're using a limbal technique, not the fornix technique. So you've got this flap of conjunctiva, and you can just use that Tecile glue to also close the conj. So it saves an extra step there. It's one less possibility for a corneal dellen or erosion, which occasionally can happen with limbal surgery.
And you don't find any restriction from doing it that way, right? Once you bring the conjunctiva forward, also with the Tecile, it's not all stuck in there. The muscle movement is absolutely fine.
You mean restriction of the conjunctiva?
Or the conjunctiva, or the muscle itself? If it does it form like a blob, or is it pretty?
No, I mean it's
easy?
so thin. It's so thin. I mean, you asked the question: did we compare hangback with glue versus hangback? And the answer is no. And that's been questioned. We presented this at AAOS back in 2009, and also at the AAO in 2019, and AAO at 2019 as well. And we had big plans to do a rabbit study and had ethics ready to compare those head to head in a prospective study. And of course, COVID hit. So we haven't looked at those 2 comparatively. And perhaps that will happen in the future.
When you were doing the analysis, Ning, what was the most interesting piece of or data or outcome that you came up with that you weren't expecting? Was it better than you thought it was going to end up being? Or was your hypothesis just met?
Well, I'll be honest, these are Dr. Wright's patients, and I'm continuously amazed at his amazing outcomes. And I did my fellowship with him. So as I'm analyzing his data, I thought, darn, he's just so good. But that confirmed what I knew. I think one of the pieces that came out, because you always want to have, when you're comparing 2 groups, demographics and as similar groups as possible. So we did see that the group that had the hangback, because initially they were patients where Dr. Wright was operating and said, wow, that sclera is super thin. It's really blue. I don't know. This is, you're feeling nervous that you could potentially perf the sclera. And so they were basically case by case looking at, was this a -16 myope and you're doing a lateral rectus recession? So I guess not too surprising, but when we compared the groups, we did find that the hangback glue group did have more myopia and larger lateral rectus recessions. And we mentioned that in the paper. So I guess that came out. And initially I thought, darn, the groups aren't perfectly equal, but then it also made sense that that's the group that we want. Whenever I'm operating with a resident or a trainee, I say, okay, just remember, where are we now? We're over the macula. This is, no one speak in the OR. Let's be really careful that we don't go too deep.
And so are people picking up this technique now? And have you heard from across North America if people are picking it up, and how is it impacting our patients? Is it happening, or are you guys still, are you trying to?
I don't know. We're all in our little bubbles with COVID. So I think things are slow to change. And I would say possibly, really only knowing my field, but I think pediatric ophthalmology perhaps is even slower to move than other specialties. We first presented this, like I said, a couple of years ago now, originally our pilot data at the AOS, and there was a lot of interest. And we were happy because the AAO and APO, so the American Association for Pediatric Ophthalmology and Strabismus, they did a joint webinar, like a journal club, I think in September, and they had Dr. Wright on talking about this paper. So that was, to me, indicated that there's some general interest. If the AAO is interested, if CJO is interested. I haven't asked my colleagues if they're doing this, but we've presented many webinars and lectures sort of over the last year and a half, and a lot of good questions. So I'll be at the AAO in a few days, and we'll be presenting this along with some other minimally invasive techniques, and we'll see how the reception is there.
Is that what you're teaching at the skills transfer courses at AAO, or are you teaching more basic strabismus, the old-fashioned technique?
The old-fashioned. I wouldn't say it's basic, because the audience who takes our skills courses at the AAO and elsewhere are a lot of pediatric ophthalmologists that want to learn some new techniques, some general or neuro-ophthalmologists who also do strabismus. So prior to I guess it was 2 years ago now, and this year, teaching things like central tenotomies, central plications. These are my residents, if they happen to listen to this, will say those are normal things we just learned. But if you trained 20 years ago, those had not been invented yet.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Good evening. My name is Dr. Robert Kunikov. I'm a pediatric ophthalmologist, and I work at the Montreal Children's Hospital of McGill University in Montreal. And I follow the EyeCan podcasts.
It's amazing how in everything that we do in surgery, we're trying to be more efficient, more safe as well, and obviously we want effective techniques. And so you alluded to a little bit of the fact of minimally invasive surgery. So what can you tell us in pediatric ophthalmology, and specifically in strabismus surgery? Are there any new developments in terms of making things easier, in addition to what you have reported, but are there any other new concepts, muscle spacers, or things that will make the surgery safer, faster, and also equally effective?
Yeah, those are great points. And the term minimally invasive surgery, it's thrown around a lot. So I like how you defined it. It should make the surgery shorter, safer for the patient, easier for the physician. And I don't think that's something bad to say. We should make things easier. That's good. A lot of the techniques I just alluded to in the skills lab, those are ones that Dr. Wright had invented and pioneered, and others in our field have done different modifications. I think one of the biggest changes since I was a resident was I almost never do resection. So if you recall, cutting out a piece of muscle,
Yes. Mm-hmm.
I do almost purely plications, which is folding the muscle. So if you need to undo it, you can. It preserves the blood flow, etc. And now you can also do a central plication. So it's like a mini bringing up of the central part of the muscle. And that's for very small angles. So it takes away the need to do adjustable sutures, which is very time consuming. And a lot of patients really, I would argue most patients don't like it. It's painful. And it just gives you more options, because now that all the cornea people are doing this amazing refractive surgery, and people don't want to be in heavy prism glasses. That's really limiting.
Excellent. Actually, I'll just pick up on that quickly. You mentioned refractive surgery. What is your opinion of refractive surgery in kids? There have been a few reports. There have been a few instances. There's now more and more discussion with this epidemic of myopia that we're seeing. Is there any role for some of the current corneal refractive surgery procedures that we have to be more involved with you guys, with pediatric ophthalmologists?
Yeah, I won't pretend to be an expert in pediatric refractive surgery, but I think you alluded to two big things: the increased myopia, so that's huge. Hopefully, this isn't going to be a gigantic population that all of a sudden we have to do refractive surgery in kids. The biggest issue is the variability and the change with anything in children. So until they reach 18, 20, or arguably into their mid-20s, there's so much change. Refractive surgery is being done, as I'm sure you know, at sick kids for children who just can't wear glasses or the contacts are difficult. So I think it's an option. I don't know. At least in my perspective, we're looking, how can we prevent the so-called epidemic of myopia? So I'm hopeful, although I love to operate, I'm hopeful that it's not going to be something where every child needs refractive surgery.
Good. Excellent. Thank you.
It's really clear, speaking to you, Ning, that you're passionate about what you do and about strabismus. Can you tell us some of your other areas that you're interested in, and what do you spend the rest of your time doing?
So another area, it kind of ties in nicely with the things we've been speaking about, is simulation surgery. So I've been involved with teaching Strabismus surgery at the AAO and at the COS, and I'm excited to be an in-person skills transfer course at COS next year. And it's an interesting story. If you bear with me, I think it was 2017, I did the skills transfer course at COS, and a resident at the time, he was PGY3, said, "Can I show you something I'm working on?" And I thought, yeah, sure, why not? And he sent me photos of these 3D printed silicone models. And then he completely wowed me. And I said, sure, come along. And long story short, we've been working together since. He's now an oculoplastic surgeon in Winnipeg. And he's not even in pediatrics, despite all of my enthusiasm. And he's traveled with me around the world to different meetings with this model, which has been super exciting. So we went to India together for the World Congress of Pediatric Ophthalmology and did an Orbis 2-day teaching session. And more recently, which was really cool, trying to find the silver lining in COVID, we did a virtual strabismus surgery skills teaching session with WISPOS. So we had students from China and South Africa and Europe and Asia, sort of everywhere, and then 2 students to 1 instructor with our models, teaching them different techniques through Zoom. And it worked remarkably well. And there was a lot of excitement on both sides. I had the opportunity to meet new students and teach people from countries I've never even been to yet. And they got to learn from instructors that, places where they don't even have a pediatric ophthalmologist. So I really love strabismus and I love teaching it. So I'm excited to, as fun as the virtual was, I do miss in person. So hopefully we're going in the right direction.
Yeah, I agree. Actually, that's a really good plug-in for Winnipeg and Manitoba, because I know that's exactly where that was developed. So that's great. How do you think that that you can evolve some of these techniques, and what do you expect to see in terms of the the patient population in pediatrics with some of these new techniques? Do you think their recovery is faster with some of these techniques? Is it simply the safety? But how does it deal from the point of view of the patients, the parents providing the care? What's your opinion on that, Yining?
Whenever I take the time to go through informed consent with parents, it's so much easier. We go through the worst case scenario. You could possibly have a retinal perforation. There's possible vision loss, although extremely low. And it's so much easier to explain to a parent that there's almost no risk of vision loss with some of these techniques. And I would say most parents, they understand we're not removing tissue. We're trying to be as quick as possible. Our surgeries are all done predominantly under general anesthesia. So we want to limit the anesthesia time. And in terms of recovery, I think our patients do great. Now, patients, I think overall do very well with strabismus surgery. So I can't say, is it significantly better? When you start removing the sutures and just use the glue to close the conch, for sure, patients are more comfortable. But I do think, I'm always cognizant of how little OR time we have. Everyone is right now with COVID. So it's always in the back of my mind, how can I operate on more patients, make my wait list less without compromising care? And I'm in a teaching center too. So I want, it's my duty to teach my students. And of course, I want them to go out and be comfortable with muscles, even if they don't go into peds, although it's the best specialty out there. So those of you listening, consider it. But, so I need to make my patients have the best outcome while still teaching, and again, limit that wait list. So I think whenever we can make a surgery faster, and faster is, my mentor would say the best way to go fast is go slow. So when I feel comfortable and when there's less stressful parts of the procedure, I can allow my resident to participate, and the day just goes that much smoother. So I think it's a win-win for everyone.
Excellent.
That's great, Yining. Just in the last few minutes, do you want to tell us a little bit about yourself outside of work and what your interests are? And we'd love to get to know the home Yining as well.
The myth, the legend.
Oh my goodness. Well, see, if we were in person, we'd be opening up a bottle of wine, and that would make it so nice, but we don't have time or the ability for that yet. So, well, for those who know me, I have 3 pretty active young boys. All under 10, and they keep me pretty busy. They're full of energy that I wish I had. And I have a very supportive husband, Sham, who lets me do, podcasts while the kids are upstairs trying to be quiet. So I'd say, obviously family is important. Cetera, I'm part of the Women in Medicine group that you so amazingly formed. And that's been huge for me. So I think in the last, I guess it's 3 or 4 years, focusing on women in medicine and wellness and how we can lead in ophthalmology in a very positive way, because it's easy to get sidetracked. So I think, without going into too much detail, those have been my focuses. And it's been hard during COVID. And I think having wellness opportunities and leadership opportunities and connection has been huge. So everyone's involved in this. I know you are, Cetera, in a big way. And we're trying to teach our residents and our colleagues how to get through this.
Yeah, I agree. There's a lot of work to be done. And and we'll do it together, Yining.
Yeah.
We'll keep
wine.
Yeah, exactly.
Yining, before we let you go, there seems to be kind of a lack of pediatric ophthalmologists in Canada. I often hear that, maybe I'm not as involved with that. So how do you see the situation currently? And also, what message would you have for those residents that are considering different subspecialties? What should they consider, and what should they know that should attract them to pediatric ophthalmology?
Yeah, I love this question. And it's very true. You're not imagining it. We need pediatric ophthalmologists. There's not enough. There's very few of us, and a lot of them are probably retiring as we speak. I feel strongly, I tell the residents, it's important that you go for a specialty that you're interested in. So I'm not going to try and convince someone who's not interested in pediatric ophthalmology. But I must say, I love the specialty, and I do adult strabismus too. So we keep saying pediatrics, but it's quite fluid. I see probably 50-50 kids and adults. For me, it's an extremely satisfying career, and you can make it what you want. So it's very broad. I know a lot of trainees are worried about getting too narrow focused in one specialty. And the lovely thing about pediatric ophthalmology is you can do as much or little as you want. So my main focus is strabismus, but of course you can do pediatric cataract, cornea, plastics. And I think, life's pretty serious, and there's lots going on. And when you get to see kids every day, it's very energizing, even for someone tired like me. So, kids, it's a very fun specialty. And I guess part of it is you have to sort of be flexible to work with the patient. And what I find really challenging and fulfilling is a child who may be shy or in quotes difficult, and you win them over and you get the information you want. And you've made a huge impact in this patient for decades. So for me, I don't regret it at all. And my students know that I really love peds. So for those of you listening, if anyone's interested, someday we'll take observers from out of town. And it's a big issue, though, that our societies are working on. How can we make this more attractive? And maybe that's for another podcast. There's a lot I could say about that.
For sure. No, we'll hang on to your passion for it. And we really would like to thank you.
It was really nice to have you on the show, Ning. I do remember learning how to weave through the muscle and into the sclera very, very vividly for some reason, maybe because it was always a little bit stressful, but I hadn't spoken about it in many, many years. And it's so lovely to hear someone with such passion for what they do. And congratulations on not just this article, but it seems as though you are going to be a change maker in pediatric ophthalmology. You are already, and it's been really nice to speak to you tonight.
Well, thank you. Those are very kind words, and I'm honored to be part of this podcast.
Thank you to our guest, Dr. Ning Strube, for joining us. Here's what's coming up on our next episode.
Hi, I'm Nupra Bakshi. I'm a retina and uveitis specialist at the University of Toronto, and I am the chair of the EDI working group for the COS. And I'm thrilled to be here today on the EyeCan podcast.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
The EyeCan podcast has been made possible by support from MD Financial Management and Scotiabank, proud financial partners of the Canadian Ophthalmological Society and Canada's ophthalmologists.
Thank you to the Canadian Ophthalmological Society.
The EyeCan podcast is written and directed by Eric Johnson and produced by John Allaire from Allaire Strategic Works.